Welcome to Hersing University NU 640, Introduction to Women's Health Across the Lifespan. This video will discuss Chapter 23 from your Alexander and Colleagues textbook, as well as Chapter 14 from your Sarkio and Secor text. This discussion will serve as a brief overview of the material. Therefore, I would like to ask that you please read the chapter for additional and required information. I would also like for you to review all other required and supplemental resources. To note, this presentation will be given by Drs. Alicia Sutton and Lauren Ashton.
Women's health care during pregnancy begins with a complete history and thorough physical examination during their initial visit. The purpose of the first office visit is to identify any risk factors influencing the mother and/or fetus. A plan of care for the entire pregnancy can be developed from this one visit. So how many times will you need to see a woman for her prenatal care? There's a variation as to how every clinic performs their prenatal visit schedule, but typically the woman will present for confirmation of pregnancy and labs and then be scheduled to see the provider again in about 2 weeks. This is nice for a couple of different reasons. One of the lab results can be returned and assist in some of your clinical decision making. And two, because some women may have spontaneous abortions at such early stages. However, by the 10th to 12th week, the likelihood of that decreases. At the initial prenatal visit, a number of screening tests are performed in conjunction with the complete health history. So you're going to get a complete health history and screening. It's very important to get a genetic history and, of course, perform a physical exam with uterine sizing. Signs and symptoms that may be reported by your patient are traditionally categorized into 3 groups: presumptive, probable, and positive. I have included this table as you will need to differentiate between presumptive, probable, and positive signs of pregnancy when you have a patient present at their initial visit. I've touched on these a bit under the normal physiologic changes, but basically, presumptive signs are the softest and least objective signs. They can be caused by many other conditions besides pregnancy. These are things like amenorrhea or breast changes. Probable signs include abdominal enlargement and a positive pregnancy test. And positive signs are just that: ultrasound, palpation, fetal heart tones. Remember that you must see it, hear it, and feel it. Also remember that although these signs and symptoms assist in confirming the pregnancy, they cannot necessarily enable you to differentiate an intrauterine pregnancy from an ectopic pregnancy. It is important to diagnose pregnancy as early as possible to maximize the benefits from health care and minimize risk to the developing fetus. During the initial visit, you will perform a beta HCG urine test, auscultate for fetal heart tones, or perform an ultrasound. If all 3 are negative but pregnancy is still suspected, you can retest with a serum beta HCG. The beta HCG is an important indicator of the viability of a pregnancy. It is useful only in the first trimester and then loses its predictive value, so you really won't rely on this after week 12. A normal finding is that it will double every 48 hours during the first 12 weeks. In an ectopic pregnancy, you will see lower values than normal, and in an inevitable abortion, the values will start decreasing rapidly. And you most definitely are going to need to know Nagel's rule, which is the old-fashioned way of taking the patient's day of the last menstrual period, counting back 3 months, and then adding 7 days, and then adding 1 year for the estimated due date. Pregnancy is 280 days or 40 weeks, and term pregnancy is typically 38 weeks and beyond. Accurate pregnancy dating is vital to providing good prenatal care throughout the pregnancy. The lab and screening studies that should be ordered depend on accurate pregnancy dating. I have included a patient educational article from ACOG regarding routine tests in pregnancy for your review under the Supplemental Resources module. The laboratory tests include: if you've not already confirmed the pregnancy, you will get a urine HCG to document or an ultrasound. You'll also get a urinalysis with culture of every initial OB patient. A CBC, you'll determine their Rh status, antibody screen, and a hepatitis B antigen. You will also want to consider a RPR or VDRL for syphilis, rubella status, obtain diagnostics for chlamydia or gonorrhea as needed, and you'll want to perform a PAP unless there has been a normal exam within the past year. All patients should be offered and encouraged to complete HIV testing, and other testing is based on the patient's history. By this I mean things like genetic testing. You will also want to consider toxoplasmosis, hepatitis C if the patient falls into a high-risk category such as an IV drug user. You'll also want to inquire as if your patient has a history of herpes simplex. There's really not a routine screening for this, but if there is a history, you will need to put this on the chart because at 36 weeks gestation, you're going to start treating with prophylactic antiviral. If you recall from chapter 22, a common acronym that describes screening for most of these congenital infections is known as a TORCH screening. TORCH stands for toxoplasmosis, other viruses such as syphilis, HIV, measles, etc., rubella, cytomegalovirus, and herpes simplex. To help you understand more about these infections, I have included a lecture under the Supplemental Resources module. So this initial history and physical that you're obtaining is setting up really the treatment plan for your entire pregnancy. Now these tests will depend on the area in which you're practicing. The patients may or may not need to be tested for TB, varicella if the patient does not recall having chickenpox. You will get a titer and place that on the chart, so that can be given in the immediate postpartum stage. If you recall from Unit 1, varicella is not recommended during pregnancy. Same thing with rubella. And according to ACOG, we must be getting a very detailed history to determine if we need to be having additional genetic testing performed. In regards to the physical examination, you will need to know the uterine sizing and fundal height. So if you are palpating the non-gravid uterus, it should be the size of a lemon, mobile, firm, and non-tender. If you have an 8-week gestation, the uterus will be the size of a tennis ball or a small orange. At 10 to 12 weeks gestation, you will obtain and assess the patient's weight, blood pressure, pulse, and fetal heart tones. It's also very important to assess for signs of depression and domestic violence, along with their iron and folic acid intake. You will not need to perform a pelvic exam at this visit unless there is signs of infection, bleeding, or abdominal discomfort. Additionally, we can begin to screen for some of the neural tube defects, such as Down syndrome. It is important to note that these are to be offered to every one of your patients, and your patients will decide if you will perform the screening or not. You must document that they were offered this and the patient's decision. ACOG advises that all pregnant women, regardless of their age, should have the option of diagnostic testing. Upon physical exam, at 10 weeks, the uterus will be the size of a baseball, and at 12 weeks, the size of a grapefruit. At 12 weeks, the uterine fundus will rise above the symphysis pubis.
At 16 to 18 weeks gestation, you will again obtain and assess the patient's weight, blood pressure, pulse, and fetal heart tones. If you will notice from the table on page 423, you will also assess for signs of depression and domestic violence at every visit. You will ensure the mother is taking prenatal vitamins, and you will want to counsel her on lifestyle factors such as healthy nutrition, weight gain, and exercise.
According to ACOG, women found to be at an increased risk of having a baby with Down syndrome with first trimester screening should be offered genetic counseling and the option of CDS or mid-trimester amniocentesis. These include women who will be greater than 35 years of age when the baby is due, a family history of birth defects, a previous pregnancy where the baby had a birth defect, and in women with type 1 diabetes. They also recognize that a woman's decision to have an amniocentesis or CDS is based on many factors, such as a family or personal history of birth defects, the risk that the fetus will have a chromosome abnormality or an inherited condition, and the risk of pregnancy loss from an invasive procedure. Of course, this is all performed after you do the initial screening and refer your patients. At 16 weeks, the uterus will be between the symphysis pubis and the umbilicus. If the patient is a multigravida, this will be earlier for them. But by 20 weeks, there should be quickening or movement of the baby that is being felt. You always want to ask about this because it is a means of determining fetal well-being. So you can ask your patients, how has the baby been moving? Is there any change in the baby's motion, such as more or less? And you will always want to document the fetal movement. And in regards to fetal movement, you will always want to educate your patients to perform kick counts. So greater than 4 movements in an hour or greater than 10 movements in 2 hours is acceptable. Now, around 20 weeks is when we will begin to measure fundal height with a tape measure. To accomplish this, you will place the 0 point of the tape on the upper edge of the syphus pubis, and you will pull it rather taut over the abdomen until the fundus is palpated. The measurement should be within 2 centimeters of the estimated gestational age. There should be about a 1 centimeter increase in fundal height per week. You can have a plus or minus of 1 to 2 weeks, of course. Anything greater warrants an ultrasound to rule out growth restriction or decreased amniotic fluid. You will also begin educating your patients regarding preterm labor. 28 weeks. Now I want to begin stating that if there is a strong family history or a previous history of gestational diabetes, then you will test the mother earlier. And then you'll repeat it again at 24 to 28 weeks. But generally, you will do the glucose intolerance test at this time. And you will look at the Rh factor. An anti-D immune globulin is given to women who are Rh negative. Also administer a Tdap vaccination between 27 and 36 weeks if it is needed. And at 28 to 32 weeks, you will also begin looking at sexually transmitted infections. All patients should be screened for group B strep at 35 to 37 weeks gestation. This must be documented so when your patient goes into labor, they can be given the proper medication to avoid transmission to the baby. If they are scheduled to have a repeat C-section, you will go ahead and still swab them in the event that they have a spontaneous rupture of membranes. And lastly, when your patient arrives at the 40th week, you will begin vaginal exams to assess the cervix and fetal position.